My name is Dr. Craig Cranford. I'm a foot and ankle surgeon and I practice in Sarasota, Florida. We'll start with the standard fibular approach. With the benefits of a cadaver, we can go all the way down through the skin, straight down to the bone. Then what you want to do is you want to peel back the periosteal and capture structures like you would usually do in your normal surgical process to fix a distal fibular fracture. Once you get good exposure and you see your fracture fragment or your fracture piece, then we can start to put it back together with the hardware. So in this case, we'll make an oblique fracture just so we can show you the new Arsenal plating system. We'll just be opening up our fracture with osteotome so we can show you how we get it back together with the new plating system from DJO. With these type of oblique fractures, most of the time you'll want to do a lag screw that's completely surgeon preference. Most of the time you will go from superior to inferior. Because of the dissection, we're going to go from posterior to superior, and we'll start by drilling the lag screw hole first. The beauty of this system is you can use the drill guide to drill the pilot hole first, and then you can clearly flip the instrumentation and you can go right into your pilot hole, which means there's less moving as far as the fracture fragment. There is less instrumentation that's used, and you can use it all within one hand. Now we can flip it, the instrument, and we can put it back into the hole and we can drill again. We will then countersink after drilling, and then we'll take the measurement through standard AO principles and techniques. And then we'll place our 3.5 non-locking screw. Now we're going to place our 3.5 non-locking dually threaded screw that seats faster than standard screws. Some of the new features of the DJO Arsenal ankle line is the symmetrical fibular plate. Some of the features include 60 degrees of variable angle. It has its dual lead thread technology. It comes between 8, 10, and 12 hole sizes. It has a syndesmotic hole and these holes are used for flexible and rigid syndesmotic repair. How to fixate the plate to the bone. My technique of choice is I like olive wires. This plate allows you to use olive wires through the many olive wire holes in the plate. Also, you can use the many different locking and non-locking features of the plate for fracture repair. We'll go ahead and fixate the fibula with the olive wires. My preference is 2 olive wires because once we have the plate fixed in the position that we want, we can always check the position under intraocular fluoroscopy without affecting your fracture fragments. So I know that every surgeon has their own fracture repair preference. Mine is to use a non-locking screw initially to get the plate seated well onto the bone. And in this case, we'll use our standard drill for the size screw that we're going to place. Then we'll do our standard measure with the depth gauge. And you'll place the appropriate size screw. Which you can see will put the plate down on the bone nicely. So now my preference is to place locking screws to fixate the plate to help maintain my reduction in the fibula. And place our locking screw. You'll do this continuously through the plate. One of the unique features of this plating system is the 60-degree variable angle. This plate tends to sit more anatomic, so it sits a little bit more distal, where the skin is a whole lot thinner. The advantage of being able to drill in multiple angles to lock down my fracture fragment and still have the ability for it to seat into the plate. Next, we'll pull the olive wires out. Take final x-rays, and if everything looks in good position, we'll go ahead and close. Some of the features of this plate is it maintains its 60-degree variable angle for screw placement. It has the dual lead thread technology. This plate, however, is left and right specific. It has a 6, 8, and 10 hole plate option. It has a syndesmotic hole, as you see in the other ankle fracture plates, and this allows for flexible syndesmotic repair and rigid syndesmotic repair. When fixing a fibular fracture, everybody's technique is different. I like plate stability, so I usually fixate my plate to the fibula using olive wires first. This allows me to check under intraoperative fluoroscopy to see my alignment of the plate on the fibula and allows me to check my reduction. Everybody has their own technique. However, I always like to throw a non-locking screw in to help seed the plate down to the bone. Then I will measure and then place my non-locking screw. As you can see how well that just seated into the bone. And as you can see, you can use your variable angle technology to suck down the distal fibular part if it lifts when you put your non-locking screw in. So this plate allows for rigid and flexible syndesmotic repair. And you would do that in your standard fashion. You would go through the syndesmotic hole, aim 30 degrees, and drill across, going through all 4 cortexes. Then you'll measure. And you do have the option to place 2 syndesmotic screws if available. So once you get to this point, clearly you'll want to drill and fill. This is for demonstration purposes. So once you're happy with your x-ray with AP and lateral views, you'll remove the olive wires and you'll do a standard closure.